If you're over 70, the medical test your doctor just ordered could be doing more harm than good. I know that sounds shocking, especially when we've been taught that more screening equals better health. But what I'm about to share with you today might completely change how you approach your medical care. In my 23 years as a geriatric physician, I've seen too many seniors suffer serious complications from tests that were never necessary in the first place. My name is Dr. Helen Brooks, and I specialize in geriatric medicine with a focus on evidence-based care for older adults. I've dedicated my career to helping seniors navigate the complex medical system and avoid unnecessary interventions that can actually reduce quality of life rather than improve it. Before we dive in, if you haven't subscribed yet, I strongly recommend hitting that subscribe button and turning on notifications so you never miss another health tip made, especially for you. If you find this video helpful, please leave your questions and video suggestions in the comments below. I read every single one, and it helps me create more content to help people just like you. Now, I want to be very clear about something from the start. I'm not saying you should avoid all medical testing. What I am saying is that as we age, the risk-benefit calculation changes dramatically. Tests that made perfect sense when you were 50 or 60 might cause more problems than they solve at 75 or 80. Let me explain why through real stories from my practice and the latest medical understanding. Let me tell you about Margaret, a vibrant 78-year-old retired teacher I met 3 years ago. Margaret came to see me after her previous doctor ordered a routine colonoscopy. She was terrified, not of the test itself, but because her neighbor had recently suffered a serious complication from the same procedure. Margaret asked me a simple question that changed everything. "Doctor, do I really need this at my age?" That question made me dive deep into her medical history. Margaret had already had 2 normal colonoscopies, one at 50 and another at 60. She had no family history of colon cancer, no symptoms, no blood in her stool, nothing concerning whatsoever. Yet here she was, being pushed toward a 3rd screening that carried real risks. The bowel preparation alone could have caused dangerous dehydration and electrolyte imbalances. The sedation posed cardiovascular risks, and the procedure itself, while generally safe, carries a small but real risk of perforation, bleeding, and even death. Here's what most people don't understand about colonoscopy screening after 70. The benefits of finding early cancer decrease significantly because it takes years, sometimes a decade or more, for colon polyps to turn into cancer. If you're 75 or 80 with a normal screening history, the chances of developing colon cancer that will actually affect your lifespan are incredibly small. Meanwhile, the risks of the procedure remain constant regardless of age. In fact, they increase because older adults often have other health conditions that make sedation and the procedure itself more dangerous. Margaret's case isn't unique. I told her that according to current medical guidelines, routine colonoscopy screening can generally be stopped after age 75, especially in people with consistently normal results. She was relieved beyond words. 2 years later, Margaret is thriving, traveling, spending time with her grandchildren, and living without the anxiety of unnecessary medical procedures hanging over her head. If you're still watching and finding this information valuable, comment 1 below to let me know you're with me. It helps me understand what content resonates with you. But colonoscopy isn't the only test that becomes questionable after 70. Let me tell you about Robert, an 82-year-old former engineer who lived independently and managed his own finances, drove himself to appointments, and volunteered at the local library twice a week. Robert's doctor ordered a PSA test, a blood test used to screen for prostate cancer, during his annual physical. The result came back elevated. What followed was a nightmare that Robert describes as the worst period of his life. The elevated PSA led to a prostate biopsy, an uncomfortable and invasive procedure. The biopsy showed a small area of low-grade prostate cancer. Suddenly, Robert went from a healthy, active senior to a cancer patient, consumed with anxiety. He couldn't sleep. He stopped volunteering. His family was in turmoil, pressuring him to undergo aggressive treatment. Here's the critical truth about prostate cancer screening in men over 70. Most prostate cancers in older men are slow-growing and will never cause symptoms or affect lifespan. The vast majority of men with prostate cancer die with it, not from it. Studies have shown that aggressive screening and treatment in men over 70 often causes far more harm than benefit. The treatments, whether surgery or radiation, can lead to incontinence, erectile dysfunction, and serious quality of life issues, all to treat a cancer that would likely never have caused problems. After extensive discussion with an oncologist who specialized in geriatric care, Robert chose active surveillance, which means monitoring without immediate treatment. That was 4 years ago. His cancer hasn't progressed, and he's back to living his life fully. But he told me something heartbreaking. "Doctor, I wish I'd never had that test. I lost a year of my life to worry and anxiety over something that wasn't even threatening me." Robert's words haunt me because I hear similar stories far too often. The major medical organizations now recommend against routine PSA screening in men over 70, particularly those with a life expectancy of less than 10 to 15 years. Yet many doctors continue ordering these tests out of habit or fear of missing something, without considering the cascade of interventions and anxiety that can follow. If what I'm sharing surprises you, wait until you hear about the next test on this list. It's one that many people consider absolutely essential for heart health, but the evidence tells a very different story for those over 70. Let me introduce you to Dorothy, a 74-year-old woman who had been living a quiet, peaceful life until her doctor ordered a cardiac stress test. Dorothy had no chest pain, no shortness of breath, no symptoms whatsoever. She walked 3 miles every other day without any problems. But because she had high blood pressure and diabetes, both well controlled with medication, her doctor wanted to screen for hidden heart disease. The stress test came back abnormal. Dorothy was immediately sent for a cardiac catheterization, an invasive procedure where dyes and catheters are threaded through blood vessels to visualize the heart arteries. During that procedure, she suffered a rare but devastating complication. A piece of plaque broke loose and caused a small stroke. Dorothy, who had walked into the hospital without any symptoms, left with weakness on her left side and slurred speech. It took her 6 months of intensive rehabilitation to partially recover, but she never regained her previous level of function. This is what we call a cascade effect in medicine. One unnecessary test leads to another, more invasive test, which leads to a complication that causes real harm. Here's the medical reality. Screening stress tests in people without symptoms, especially older adults, frequently produce false positive results. These false positives lead to more invasive testing and sometimes unnecessary procedures that carry significant risks. Current cardiology guidelines do not recommend routine cardiac screening tests in asymptomatic older adults, even those with risk factors like diabetes or high blood pressure. The reason is simple. These tests don't improve outcomes, but they do expose patients to unnecessary risks. If you have symptoms like chest pain or unusual shortness of breath, that's different. But screening healthy people just to check causes more problems than it solves. Dorothy's story didn't end with her stroke. She developed depression, lost her independence, and eventually had to move in with her daughter. All of this stemmed from a test she never needed in the first place. When I met Dorothy during her rehabilitation, she asked me through tears, "Why didn't anyone tell me I could say no?" That question is at the heart of why I'm making this video. You can say no. You should ask questions. You deserve to understand the risks and benefits before agreeing to any test or procedure. Now, some of you might be thinking about cancer screening, and you're probably wondering about one test in particular that's been promoted heavily for decades. Let me tell you about Barbara's experience. Barbara was a 79-year-old woman who had been getting annual mammograms for 30 years. She was diligent about her health, never missed an appointment, and believed deeply in the power of early detection. Then, during one of her routine mammograms, the radiologist found something suspicious. Barbara was called back for additional imaging, then a biopsy. The waiting, the worry, the fear consumed her for weeks. The biopsy revealed ductal carcinoma in situ, DCIS, which is sometimes called stage 0 breast cancer. It's a collection of abnormal cells in the milk ducts that may or may not ever progress to invasive cancer. Barbara was presented with treatment options: lumpectomy with radiation or mastectomy. She was terrified. Her daughter and son were in disagreement about what she should do. The family dynamics became strained. Barbara couldn't eat, couldn't sleep, and started having panic attacks. Here's what Barbara wasn't told clearly enough. DCIS in older women is often overtreated. Many cases of DCIS never progress to invasive cancer, especially in women over 75. The natural history of these lesions is that they grow very slowly, if at all. For a 79-year-old woman with other health conditions, the risks of surgery and radiation, both the immediate complications and the long-term effects on quality of life, often outweigh the uncertain benefits. Barbara chose to have a lumpectomy and radiation. The surgery went fine, but the radiation caused severe skin burns, fatigue, and damaged her chest wall muscles. She developed chronic pain that lasted for over a year. When I saw Barbara 2 years after her treatment, she confided, "I sometimes wonder if I would have been better off never knowing about those cells. I was healthy and happy, and now I'm in constant discomfort." The major cancer organizations now suggest that routine mammography screening can be stopped after age 75, and even earlier in women with serious health conditions or limited life expectancy. The reason is that breast cancers found through screening in very elderly women are often slow-growing, and the time it takes for a detected cancer to become life-threatening often exceeds the woman's remaining life expectancy from other causes. This doesn't mean ignoring symptoms. If you feel a lump, notice skin changes, or have nipple discharge, absolutely get it checked. But routine screening mammograms in women over 75, particularly those in their 80s, often cause more anxiety and lead to more interventions than they prevent deaths. If you're finding this information eye-opening and you're still with me, leave a comment below with your thoughts. I'd love to hear your experiences with medical testing and whether this is changing your perspective. Let me share one more story that really drives home why I'm so passionate about this topic. Thomas was an 85-year-old man, a World War II veteran, still sharp as a tack, who lived with his wife of 60 years. During a routine checkup, his doctor ordered a battery of blood tests, including something called a thyroid-stimulating hormone test, or TSH. The result came back slightly elevated, suggesting mild hypothyroidism, or an underactive thyroid. Now, Thomas had no symptoms. He wasn't tired, his weight was stable, he wasn't cold all the time, he had no complaints whatsoever. But the elevated number on the lab report triggered a treatment cascade. His doctor started him on thyroid hormone replacement. Within weeks, Thomas started experiencing heart palpitations, anxiety, and insomnia. His blood pressure, which had been well controlled for years, became erratic. He fell one night getting up to use the bathroom because he felt dizzy, and he fractured his hip. That hip fracture changed everything. Thomas had surgery, but complications during recovery led to a prolonged hospitalization. He developed hospital-acquired pneumonia, lost significant muscle mass, and never fully regained his previous level of independence. His wife was overwhelmed caring for him. The last time I saw Thomas, about a year after that initial thyroid test, he was in a wheelchair, depressed, and his wife was exhausted. Here's the critical point. TSH levels naturally rise slightly with age. What's considered abnormal in a 40-year-old might be completely normal in an 85-year-old. Treating mildly elevated TSH levels in elderly patients who have no symptoms can cause more harm than benefit. The thyroid hormone medication can stress the heart, cause atrial fibrillation, contribute to osteoporosis, and create the exact kind of cascade we saw with Thomas. Multiple medical studies have shown that treating subclinical hypothyroidism, that's the medical term for mildly elevated TSH without symptoms, in people over 80 does not improve outcomes and may cause significant harm. Yet it happens every single day in medical offices across the country, because doctors see an abnormal number and feel compelled to fix it, without considering whether that number actually represents a problem that needs fixing. Thomas's story is particularly tragic because it was so preventable. A simple conversation about the meaning of that TSH result, a discussion about whether treatment was truly necessary, could have saved him and his wife from a year of suffering. But if you think that's concerning, wait until I tell you about the final test on this list. This one might surprise you because it's often presented as completely harmless and routine. I want to tell you about Eleanor, a lively 77-year-old grandmother who loved baking and spent hours in her kitchen creating elaborate cakes for her grandchildren's birthdays. Eleanor's doctor ordered a bone density scan, also called a DEXA scan, during her annual physical. The results showed osteoporosis, a condition where bones become weak and brittle. Eleanor had never broken a bone in her life. She was active, maintained good balance, and had no family history of fractures. But that diagnosis of osteoporosis led to a prescription for a bisphosphonate, a medication designed to strengthen bones. Eleanor took the medication faithfully, believing she was protecting herself from fractures. About 18 months later, Eleanor developed severe jaw pain. Her dentist had performed a routine tooth extraction, but the socket wouldn't heal. She ended up with a condition called osteonecrosis of the jaw, where the jawbone actually dies and becomes exposed. It's a rare but devastating side effect of bisphosphonate medications. Eleanor required multiple surgeries. She couldn't eat solid food for months, and she lost significant weight. The woman who had loved baking could barely open her mouth without excruciating pain. Here's what's important to understand about bone density testing and osteoporosis treatment in older adults. The decision isn't as straightforward as bones are weak, take medication. We need to consider your actual fracture risk, which depends on many factors beyond just bone density. Age, previous fractures, tendency to fall, other medications, overall health, all of these matter. The medications used to treat osteoporosis do reduce fracture risk in some patients, but they also carry risks. Beyond jaw osteonecrosis, they can cause esophageal problems, unusual fractures of the thigh bone, and kidney damage. For a frail 90-year-old with multiple health problems, the risks of the medication might outweigh the benefits, especially if they're already taking precautions against falling and getting adequate calcium and vitamin D. The decision to screen for osteoporosis and treat it should be highly individualized in older adults. Universal screening and treatment isn't recommended by many expert panels, particularly for those over 85. Yet, I see it happening routinely, with patients started on medications without thorough discussions about their individual risk profile and the potential downsides of treatment. Eleanor eventually recovered from the jaw necrosis, but she told me she wishes she'd asked more questions before agreeing to the bone density test and the subsequent medication. She said, "I thought I was being responsible by getting tested and taking the medicine. I never imagined it could hurt me." Now, I know some of you might be feeling anxious or even angry right now. You might be thinking, "But my doctor ordered these tests. Are you saying my doctor is wrong?" Let me be very clear. Your doctors care about you and want the best for you. The problem is systemic. Medical training emphasizes doing more, ordering more tests, being thorough. Doctors are afraid of missing something and being blamed. Insurance and medical liability issues push physicians toward defensive medicine. And frankly, many doctors simply aren't aware of the latest guidelines about when to stop screening in older adults. This isn't about blaming individual physicians. This is about empowering you to have better conversations with your medical team. When a test is recommended, here are the questions you should ask. What are we looking for? What will we do if we find something? What are the risks of the test itself? What happens if I don't have this test? Given my age and overall health, what does the evidence say about this test for someone like me? These are fair, reasonable questions. Any good doctor should welcome them and be able to provide thoughtful answers. If your doctor becomes defensive or dismissive when you ask these questions, that's a red flag that you might need a different doctor who respects your autonomy and values shared decision-making. Let me also address something important. I'm not suggesting that people over 70 should avoid all medical care. That's absolutely not what I'm saying. Appropriate medical care is essential. Treatment of symptoms, management of chronic conditions, medications that improve quality of life, these are all valuable. What I'm talking about is screening tests in people without symptoms. Tests that go looking for problems that might never cause issues, especially when finding those problems leads to treatments that can cause harm. There's a concept in medicine called number needed to treat and number needed to harm. For many screening tests in older adults, you'd need to screen hundreds of people to prevent one bad outcome. But you might harm dozens of people with the complications from testing and subsequent interventions. When the numbers don't add up in your favor, it's okay to say no. I also want to emphasize that your individual situation matters enormously. A healthy, active 72-year-old with a family history of colon cancer and no previous screening is very different from an 85-year-old with dementia, heart failure, and multiple other conditions. Medical decisions should be personalized. That's why blanket recommendations to get screened often don't serve older adults well. One of my patients, a wonderfully wise 83-year-old woman named Ruth, once told me, "Doctor, at my age, I'm more interested in living well than living long. I don't want to spend my remaining time running from medical appointment to medical appointment, worrying about tests and results. I want to spend time with my family, work in my garden, and enjoy each day." Ruth's perspective is one that more of us, patients and doctors alike, should embrace. So what should you do now? First, take inventory of what screening tests you're currently having. Look at your recent medical records or ask your doctor's office for a list. Second, research each test. Look up current guidelines for your age group from reputable sources like the U.S. Preventive Services Task Force or professional medical societies. Third, schedule a conversation with your doctor specifically to discuss your screening strategy. Come to that appointment prepared. Bring your questions in writing. Be honest about your goals and priorities. If you value quality of life over quantity, say so. If you want to avoid unnecessary procedures and their complications, make that clear. Most importantly, don't be afraid to say no to tests that don't make sense for your situation. I also recommend asking about stopping rules. For every test you're currently getting, ask, at what point can I stop doing this test? Many screening tests have upper age limits beyond which they're no longer recommended, but doctors often continue ordering them out of habit. Another crucial conversation to have is about your overall health trajectory. If you have significant chronic conditions, limited mobility, or cognitive impairment, aggressive screening for new problems makes even less sense. Your doctor should be helping you focus on managing your current conditions and maintaining quality of life, not screening for potential future problems that may never materialize or that you might not live long enough to experience. I want to share something from my own family. My grandmother lived to be 94. In her last 10 years, she had a doctor who understood the principles I'm sharing with you today. He stopped screening mammograms at 80. He didn't order stress tests or colonoscopies. Instead, he focused on managing her blood pressure, treating her arthritis pain, and supporting her independence. My grandmother lived those last years without fear, without unnecessary medical interventions, and with dignity. She died peacefully at home, surrounded by family, having lived life on her own terms right until the end. That's the model of care I strive to provide for my older patients. Medicine that respects your autonomy, considers your individual circumstances, weighs risks and benefits honestly, and keeps quality of life at the center of every decision. If you've made it this far in the video, thank you for staying with me. This is crucial information that could literally change your life or the life of someone you love. Please share this video with family members and friends who might benefit from this knowledge. The more people who understand these principles, the more empowered we all become to advocate for appropriate, thoughtful medical care. Before you go, I need to emphasize one critical point. Everything I've discussed today requires a conversation with your own physician. Don't stop tests or treatments without medical guidance. What I've provided is education to help you ask better questions and make more informed decisions together with your healthcare team. Every person's situation is unique, and medical decisions should be individualized. I hope this video has opened your eyes to a different way of thinking about medical testing as we age. More isn't always better. Sometimes the best medicine is thoughtful restraint, careful consideration of risks and benefits, and a focus on what truly matters: your quality of life, your independence, and your peace of mind. If you found this video helpful, please hit the like button and let me know in the comments which topic you'd like me to cover next. What health concerns keep you up at night? What questions do you wish your doctor would take time to answer thoroughly? Your input helps me create content that truly serves your needs. Remember, you are your own best advocate. You have the right to ask questions, to understand your options, and to make decisions that align with your values and goals. Don't let anyone, including well-meaning doctors, pressure you into tests or treatments that don't make sense for your situation. Thank you for watching, and here's to your health, defined not by the number of tests you take, but by the quality of life you live. Take care of yourselves, and I'll see you in the next video.